Hi, this is Ravideep Singh. I'm Associate Director with CD Architects. So, hospitals pre-pandemic were designed in a way that were more perhaps capitalist in terms of churning out more bed numbers and making most out of every square feet available. But COVID brought about a paradigm shift in terms of how hospitals were perceived and planned. I mean, a few significant areas of this paradigm shift perhaps lies in site selection. Initially, whenever someone had to design a hospital, they would look at only the economic viability of the real estate available, the catchment area, feasibilities, and so on. But now, after COVID, we're also looking at the surroundings around the hospital facility. So we saw a lot of alternate care facilities or ACFs pop up during the pandemic when we had to swiftly ramp up bed capacities and come up with 2,000, 3,000 additional beds in a span of 10 days. Now, while these facilities make sense at an isolated location, but the only drawback is they are distant from the critical healthcare modalities like operation theaters and MRIs and advanced radiology equipment, which unfortunately cannot be replicated in those alternate sites. So one good idea probably which most providers are beginning to look at is select the site strategically so that there are open spaces available around the site, which in case of pandemics or emergencies could double up as alternate care facilities as offshoots of the primary healthcare infrastructure. Now, alternate care facilities around hospitals are a much more powerful proposition in terms of care delivery and value synthesis. When you talk about healthcare and technology, I think healthcare and technology are both very rapidly evolving precincts. And technology has made healthcare very volatile and susceptible to changes. Initially, let's say 10 years down the line, we used to design hospitals which could cater influx of people, especially in the Indian context where one patient could accompany 3 or 4 visitors and you'd require waiting areas in the range of 100, 200 for say 10 to 15 OPDs. But this scenario is slowly changing with the advent of technology. We have online check-ins, pre-booked appointments. So we're slowly getting away of waiting areas. Now, what good this has done is this has allowed more hospital real estate to be used for clinical areas than only waiting areas where people would just sit and look at people which are under stress, which are ailing, and so on. So this is one positive change that technology has brought about in the healthcare landscape. So hospitals nowadays in India are seeming to ramp up infrastructure swiftly. Any client that approaches us wants to get the hospital up and running in a span of 12 to 16 months and so on, which was earlier more than 2 years. So one primary challenge that we've been experiencing working with clients is how to compress the construction timeline. Now, a few answers to that is probably changing the construction techniques from reinforced concrete to steel so that everything is fabricated off-site and erected. That is one answer. And the second is how to make the hospital more viable. So the plausible answer to that is probably researching and picking up patterns of what works and what doesn't work. Like I mentioned, waiting areas. Waiting areas are slowly getting obsolete, making room for more clinical spaces to help patients recover better. So that is one area. And second plausible answer to this question is take a existing building and make it operational into a hospital, which we call as brownfield projects. But brownfield projects have their own challenges in terms of fixed deck-to-deck heights and augmentation of optimal services for mechanical, electrical, plumbing, and so on becomes tricky. So whenever we're selecting a brownfield site or an existing building, a careful analysis needs to be done in terms of what actually the end goals of the hospital are in terms of the departments the hospital envisages to create right now and 10 to 15 years down the line during its life cycle. So those are a few areas, I think, of primary challenges, but we've been trying to find answers to those questions. So when you talk about hospital architecture and sustainability, it's like a battle against competing odds. Towards one end of the spectrum, we look at the numbers, we find that the hospital infrastructure is seemingly deficient in India and we need to ramp up and create more infrastructure swiftly. But towards the other end of the spectrum, we see hospitals are the major churners of energy and creating more infrastructure essentially means we are adding a lot more carbon footprint to the environment. So the answer lies somewhere in the middle, wherein probably we could pick existing buildings and turn them into hospitals, or probably cohort services, like we can break the hospital apart into an outpatient facility and an inpatient facility. Now, in practice, which India is slowly adapting, and this is widely followed in the West, wherein you have separate buildings for medical offices, separate buildings for critical care, separate buildings for surgery and outpatient surgery centers. So that is a new model of healthcare which is slowly coming out, and basically different departments of the hospital are functioning as standalone units. So that brings down the cost of operations significantly. So CD Architects is a multidisciplinary architectural practice that specializes in designing hospitals. Our firm has been associated with designing hospitals since past 2 decades. It started with Max Hospital in Saket, which was back in 2003. And then the entire fleet of 13 hospitals from Max Healthcare followed. Apart from that, we've been associated with various public and private sector clients like All India Institute of Medical Sciences and various state and regional government hospitals. Doing hospitals in different states, delving into different territories and different geographies and different demographics has given us a fair socio-economic understanding of how the demographics are different in each state and how the healthcare needs to respond appropriately in terms of designing spaces that are more conducive, more flexible, and more receptive to their needs. For example, hospital inside Delhi or Mumbai would be very different from a hospital in a small town in Karnataka. So that is one aspect. And second aspect is our association with the top healthcare providers in the country and their vision to establish healthcare and become beacon in the global healthcare industry have allowed us to comply with global standards, follow principles of research that has been happening overseas in the West primarily, such as evidence-based design and how to bring more value in healthcare systems through facility. You talk about user experience, patient centricism, and more recently, behavioral health. So behavioral health was, I believe, is slowly becoming a more relevant part of one's overall health and well-being, predominantly stigmatized, but slowly gaining reasonable acceptance in terms of how one should respond to behavioral health, even from a facility design standpoint, because anyone who enters a healthcare facility undergoes some degree of stress from invasion of privacy, medical bills, insurance, and so on. So how as we as healthcare designers can mitigate that stress to some extent, I guess is the biggest value we bring to the table from a patient standpoint. So at present, we're associated with most of the top private and public healthcare providers of the country, Max Healthcare, Fortis, Paras, Apollo, a few selected names to mention. And in the public sector, we've been associated with All India Institute of Medical Sciences and several state government institutions for setting up hospitals and medical colleges, because probably ramping up the bed numbers and infrastructure is not only the right answer. We need more trained medical practitioners and we need more medical colleges to produce them.